All right, thank you, Paul. I hope everyone's feeling energized from that movement break. Welcome back. So in this segment, I really want to tackle some of the most challenging motor symptoms in Parkinson's disease, motor fluctuations and dyskinesias. So to help me do that, I've invited some of our best and brightest Parkinson's specialists in the Sacramento region to help me weigh in on the management of these motor complications and talk about the indications for surgical therapies in Parkinson's disease. So first, I'd like to introduce my panelists for today. I have Dr. Ehsan Hadi. Dr. Hadi is a highly respected movement disorder neurologist at Dignity Health, and he specializes in the diagnosis and treatment of Parkinson's disease. Thank you so much for being here, Dr. Hadi. And next I have Laura Sperry. Laura Sperry is a nurse practitioner with me at UC Davis, and Laura has years of experience with Parkinson's disease, and in particular, deep brain stimulation. Thank you for being here, Laura.
Thank you.
All right, so thank you so much both for being here. Let's jump right in, and we're going to start with a case. All right, so here's a patient. Mr. T is a 48-year-old gentleman who developed a right hand tremor at rest, along with changes in his handwriting. His right arm and leg started to feel more stiff, and he noted he wasn't swinging the right arm while walking. He had no other medical issues except for long-standing constipation and depression. Upon specific questioning, he reported a decrease in sense of smell. His wife noted that he moved around a lot while sleeping, as if he was acting out his dreams. There was no family history of neurologic diseases. So on our initial neurologic examination, he was found to have a rest tremor in the right hand that disappeared when he was holding posture or when he was engaged in activities. There was decrease in facial expression, and his voice was very soft. Fine motor tasks were slower and less dexterous on the right side compared to the left, and there was no weakness or numbness in any extremity. He was able to stand easily from the chair and walk down the hallway without difficulty, although there was a decrease in arm swing on the right side. So that's our patient. So let's talk about diagnosis. I'm going to turn first to Dr. Hadi and ask can we make a diagnosis based on what you've heard so far?
Well, first of all, Dr. Mulhara-Cheng, thanks for inviting me to be part of this discussion. Based on the history that you have presented, there are some key features, and that's what we look for when we make a diagnosis of Parkinson's disease. The diagnosis still is clinical based, and so if we hear or see these some of these key features, that helps us make a clinical diagnosis of Parkinson's disease. And what you have mentioned there, slowness of movements, one of the main features that we want to see when making a diagnosis of Parkinson's disease. The resting tremor meaning tremor that comes on while the patient is completely relaxed, and slowness in movements, and some stiffness that we see, gait changes. So those are all features that we would like to see when making a clinical diagnosis. So based on what you have presented, I think that diagnosis is pretty clear for Parkinson's disease.
Okay. And there was a couple of other features as well. He didn't have any other medical problems, but this gentleman had years of constipation and depression. When we asked him, he had a decrease in sense of smell, and his wife had noted that he was acting out his dreams at night. Do you think any of those things are related?
So in Parkinson's disease, we know the process probably starts years before we actually make the diagnosis of Parkinson's disease, which is based on the motor symptoms that you just mentioned. But a lot of times what we call them premotor features, and they can range from loss of sense of smell, constipation, sleep disturbance, excessive sleepiness, having movements during sleep, what we refer to as a REM behavior disorder. So these features definitely can be related or can be signs of Parkinson's disease, which people can have years before they actually get diagnosed with Parkinson's disease or develop motor symptoms of Parkinson's disease.
So at this point, is there any other diagnostic testing that is needed, or is it purely clinical?
So it depends on the expertise of the physician that this person sees. But based on the features, personally, I would not recommend any additional testing. If I've ruled out on my exam, on the history, if there's any other symptoms that goes against the diagnosis of Parkinson's, definitely I would. But in this situation, it sounds pretty straightforward. So the diagnosis is clear. As far as additional testing, not at this point, but we do have the option of having additional testing, where one of the tests that we can do is called a DAT scan, DAT, or dopamine uptake scan. It looks at very deep nuclei or deeper areas of the brain where we see that Parkinson's comes from, and that scan helps us differentiate people who have Parkinsonian features from people who don't have Parkinsonian features. So it's a good scan if we have some ambiguity about the diagnosis. Let's say you cannot examine a person because of whatever reason, or there are certain medications that can lead to Parkinson's. So in those situations, personally, is where I would recommend getting that scan done.
Great, great. So what would be your initial therapeutic approach at this point?
So that's the approach has to be said, since Parkinson's is a multi-system disorder, so multiple parts of the brain and body are involved, so we have to have a comprehensive approach. And that's kind of individualized, depends on from person to person. This is a young onset Parkinson's disease person, so I expect that he's working, he's got a family, he's very active, and he needs to remain active. So for that kind of situation, it's a decision that we make with the individual and say, we ask them how much are the symptoms bothering them, how are they interfering with their day-to-day functionality, their job, and that will help us guide the treatment. But in general, there is obviously a pharmacological aspect of treatment, but there is also a lifestyle management as well, and that includes exercise, because we know exercise is so important with different changes in the brain that exercise can help with. Increased signaling in the brain, increased dopamine, the chemical transmission, and so on and so forth. Obviously, we don't have really strong evidence for that, but I think those exercise definitely helps with those situations. So exercise, as far as diet is concerned, supplements like antioxidants, stuff like that, and looking at their mood, looking at their sleep. So all these aspects have to be addressed when you're managing someone's Parkinson's disease. But going back to your medication-wise, depending on the symptoms, depending on how the symptoms affect quality of life, we can start with some basic medications that can be as what we call MAO inhibitors. Yep. We have a couple of choices in that, 2 or 3 choices in that regards: rasagiline, selegiline, sulfonamide. So we have choices. So it basically, without going into too much detail as far as what would be the first drug, I would say it depends on the person's quality of life issues.
I agree. Thank you so much, Dr. Hadi. That was really comprehensive. So going back to this particular patient case, let's say he did start on a monoamine oxidase type B inhibitor, and he had an excellent response. So what that means is the rest tremor improved, the right-sided stiffness and slowness all got better to a good degree. And his wife even noticed that there was some improvement as well in how natural his right arm looked when he was walking. Further down the line, this gentleman was started on carbidopa-levodopa, which is a very commonly used medication in Parkinson's disease. We have a lot of different formulations out these days, and we can talk more about that later. But the carbidopa-levodopa further improved his motor symptoms. However, the patient had one complaint. The complaint was that whenever he would take a dose of his carbidopa-levodopa, he would start to feel nauseous. So Dr. Hadi, maybe you can touch on how do we deal with this situation now? We've got medications that help, but also result in some side effects.
So that's a very good point, because not everybody gets it, but when people get it, it's very uncomfortable. They're already dealing with another condition, and now on top of that, they have to deal with the side effect of a medication. So how do we address that? One way that I usually start people with levodopa is to gradually increase the dose. And that sometimes helps with better tolerating the medication. If that still doesn't work, or if the symptoms still persist, then sometimes taking it with some crackers or with something soft like that can also help. We also have to address it. What is the reason for the nausea? Is it only medication related? Because sometimes nausea can come from, just like the body slows down externally with Parkinson's disease, internally also it slows down. So, is it the gut slowing down? Is it the stomach slowing down? And that can sometimes lead to nauseous symptoms as well. So we have to address it accordingly. But if it's medication related, usually I'll slowly start the medication, because levodopa has another component in it that helps prevent breakdown of levodopa before it gets to the brain. The brain loves levodopa, but the stomach doesn't. So that's why it's formulated in a way to have that chemical already incorporated in there, so it prevents it from breaking down before it gets to the brain. Sometimes it happens still. So yeah, I mean, slowly increasing the dose, taking it with crackers, and then also sometimes we have to actually give additional medications to prevent nausea. That can be a variety of them that we know of. So if that's the situation, usually we'll have to add another medication.
What are some of the examples of what you might use in that case?
So what I will sometimes do is add more carbidopa to it. So levodopa, carbidopa, the original combination, add more carbidopa to it sometimes. Otherwise, I'll use sometimes Zofran to it, which is a pure nausea medication. Domperidone is another one, but I don't think so that's available here. So, those are our choices there.
Great. Okay. So now let's say we've given Mr. T some supplemental carbidopa in addition to his pre-existing carbidopa levodopa, and his nausea is now alleviated. So he actually does well for quite a number of years. And so let's fast forward a bit in the timeline here, and on a follow-up visit a couple of years later, Mr. T reports that his medications are not lasting as long. So each dose of carbidopa levodopa helps him, but he feels the benefit wears off before the next dose is due. So what are some of the strategies, Dr. Hadi, that you would employ to help address this wearing off problem?
So this is an expected course with Parkinson's disease, because initially, as the brain has reserves, dopamine itself has a half-life of maybe 2 hours or so approximately. But the brain can easily store it, and people can use it over time, or it works over time. But with the passage of time, as there's changes that take place in the brain and there's some degeneration, this capacity for the medication to last longer slowly goes away. And there are different ways to address that. One way is to obviously use your existing dopamine and maybe increase the dose a little bit to fill the gap. It depends on what kind of gap they're having, but if it's a wearing off effect where the medicine is not lasting until the next time, versus sometimes people don't even feel the benefit of the medicine. So if it's not lasting long enough, sometimes increasing the dose before we switch to something different, that sometimes helps. Adding another medication can help with a slightly different mechanism. If all those options have been tried, then switching the dopamine to a longer acting formulation can also help, because that can have a little bit longer half-life, and we have a formulation for that purpose as well. Additionally, I mean, if it's an off and on kind of wearing off, meaning most of the times I'm okay, but once a day I'm wearing off, in those situations we have some very short or quick acting formulations available as well, and they are absorbed through different processes, and they can have a role in those situations.
Great.
And these are newly approved.
Excellent. Thank you. So let's say on follow-up examination, Mr. T is now doing better with regard to his motor fluctuations, but you're starting to notice some abnormal involuntary movements. So instead of being able to sit quietly, there's a lot of restless, fidgety movements. And our field would call that Dyskinesias. So let's talk about any medication changes you might make in light of seeing some new onset dyskinesias.
So dyskinesia, as you mentioned, is an effect of being on dopamine, having Parkinson's disease, and then being on dopamine for within a few years people can get them. Not everybody gets it, but young people tend to get it more. And it can develop after a few years of being on the carbidopa-levodopa. First of all, first question we have to ask is the dyskinesia bothersome? A lot of times family members see the dyskinesia and they feel like, oh, things are getting worse. This gentleman is, or this person is not doing well because they're moving around or being fidgety. But for the person themselves, it actually may be a good state that they're in, meaning the medicine is working. That tells us the medicine is working, they're able to function better. But if it comes to a point, and about 20% or so of the people who have dyskinesia, the dyskinesia can be troublesome, meaning it can lead to balance issues. That's when I will intervene myself, is when they're walking and they're so wiggly that you worry if they're going to have a fall. So those are the situations, even though the person may feel like I'm okay, but I will intervene in that situation to correct that. Or if the dyskinesia is leading to abnormal posturing or pain, stuff like that. So if that's a situation, then the options are, first of all, we have to make a compromise sometimes, because you cannot have perfect of all worlds. You have to see, okay, how much of this dyskinesia is bothering me versus how much control would I like to have. And then first choice would be, is it possible to lower the dopaminergic medication a little bit? And sometimes that helps minimizing dyskinesia. If that doesn't work, then there are medication. There was a medicine for a long time, only medicine we had, to help suppress dyskinesia. And that can help in selective cases. We have a longer formulation of that medicine available now. It's called Amentidine. And we have long-acting Amentidine now, so it can be once-a-day Amentidine. So that medicine has shown to improve dyskinesia when it becomes troublesome.
Great. Okay, so let's say we made some of these adjustments. So instead of regular carbidopa-levodopa, we used extended-release formulation, carbidopa-levodopa, and perhaps we may have added some extended-release Amentidine as well. And so what happened with Mr. T is Mr. T did feel like each of those changes was associated with an improved outcome. So there was benefit. However, now we're going to fast forward some more years, and over time, he developed more and more difficulty with the motor fluctuations and the dyskinesia. So despite the medication changes, he started feeling like he was never completely on without dyskinesia. So if he was on, it was on with a lot of extra movements, or off entirely. And by off, I mean stiff, slow, frozen, very difficult to move. And so over time, the days started turning into a constant on and off roller coaster. And eventually he felt there was really no good on time without dyskinesia. And that's a challenging situation, and I want to ask nurse practitioner Laura Sperry to weigh in on when is it a good time to start talking about surgical interventions for Parkinson's.
Great, well, thank you. So we have two different surgeries that are available to patients with Parkinson's disease, and they typically start becoming part of consideration when patients have exhausted most of their medical options, their medications are not lasting as long, they're having more of the fluctuations, those periods of on or off, so basically functional and less functional parts of the day that we're just not able to fill in the gaps, or they're being limited on their therapy because of the side effects from the medications. So the two options that we have, one is deep brain stimulation, which you had an earlier talk on. And just as a reminder, this is where we put electrodes into the brain. They tunnel underneath the skin behind the ear, and they connect down to a neurostimulator, very much like a cardiac pacemaker that is in the chest. And that neurostimulator is a mix of a computer and a battery that helps send signals up to the brain and can help control the motor symptoms of Parkinson's, the tremors, the slowness, and the stiffness. For the other option is something called the Duopa Pump, and this is an intestinal version of the carbidopa-levodopa medication that you're familiar with from the oral formulations. And this pump is where we put a hole that goes into the, a PEG tube that will go into the stomach. There's a tube that will go down into your intestines so that we can deliver the intestinal form of the carbidopa-levodopa more directly. And this option may be an option for individuals who are not candidates for deep brain stimulation. Perhaps they have medical problems or cognitive concerns that may make them a slightly higher risk patient. Or in general, the idea of brain surgery is not something that they're considering. And the Duopa would then be an option for them.
Great, thank you. So in this particular situation, how would you advise Mr. T?
So the discussion definitely is a decision that's made with the provider as well as the patient. So a lot of it comes down to which option is the patient most comfortable with, as well as what option is the provider most comfortable with. So what do they have the most experience doing? And then what type of lifestyle options is this individual looking for? And do they find the idea of an electrode in the brain and a battery that will need to be changed intermittently? Is that something that they feel like they can work with? How would the idea of having a pump that would be very much like an insulin pump be, where they would have a cartridge that they would change out every day? So you have to talk about the options and the logistical components, as well as because they both target the same options. They both target those fluctuations.
Okay. Dr. Hadi, maybe you can weigh in and tell me, how do you counsel patients on making this surgical decision?
So both of these are advanced options for management of Parkinson's disease. Usually I'll talk about both these options after a few years of people having symptoms, or when they begin to have these dose fluctuations, as we call them. And based on their approach, that's how I would recommend one way or the other. But other than that, what we usually look at is that, first of all, how responsive they are to medication. That's our first step of screening people who are going to be good candidates, because we want to only refer people for these procedures because these are invasive procedures, both of them, one more than the other. So for somebody to go through that, they have to be nicely responsive to treatment. So we go through that screening process, which Laura does more than I do, I think. Once we go through that, then we assess how well will they respond to each treatment, and then have that discussion with the individual. Sometimes when we see a little bit more, people have a little more difficulty with memory and stuff, sometimes that will help us lean more towards the dopamine pump versus surgery, because with surgery you need a little bit more involvement as far as managing and the programmer. So that's how usually we have that discussion and then help them decide. But some people, they have their own, they lean more towards one or the other without any reason.
So it's clearly a team approach. You involve both the patient, the family, all of the providers. Laura, you're very involved in the candidacy evaluation for these patients. So not everyone who wants to have surgery perhaps may be good candidates. So can you tell us a little bit about the candidacy process, and what are some of the steps that we use at least at UC Davis?
So at UC Davis, individuals that are coming through the surgery process will go through a very rigorous evaluation. They will always start with their movement disorder neurologist making the initial referral. They will meet with our surgeon to have a discussion from the surgeon's perspective if they think this individual is a good surgery candidate. They will also undergo what we call on and off testing. So we will videotape them off of their medications so that we can see what are your core symptoms with Parkinson's. And then we'll have the patient come back on their medications and videotape and see how their response is, which symptoms get better when they take their medications. And this becomes really important, particularly for deep brain stimulation, because the individuals that are going to respond the best are those individuals that have dopaminergic responsive symptoms. So in particular, the tremors, the slowness, and the stiffness, So if they feel better on their medications, but we're not seeing a significant change in their motor symptoms, they may not get a strong response after surgery. And so this will help guide our recommendations of whether or not we think this is an appropriate path to follow. And then the other piece of this is we will have individuals undergo a very in-depth neuropsychological evaluation, and this can be a several-hour process. We want to get a better understanding if anybody has any existing cognitive concerns, any mood concerns, any psychiatric concerns before we move forward with our surgical evaluation. And then the last component of that evaluation is an MRI. So we want to get a peek behind the scenes. Is there anything that the surgeon needs to know about that may make implanting those electrodes a little bit more difficult?
Thank you, Laura. So it sounds like some of those things are a little bit intimidating and a little bit stressful. So tell me more about this neuropsychological testing. What does it entail?
So it is probably one of the more in-depth evaluations people have had at this point, and certainly is something that that intimidates most people coming through. Even those that come through with flying colors tell me afterwards, oh, I did awful. So don't make too many judgments as you're coming through it. But it's an opportunity for the neuropsychologist to, one, get a really in-depth history so we can understand what type of experiences, what type of education, mood issues, psychiatric issues that these individuals may have dealt with in the past. They'll have you do a variety of tests to help get a better idea of are there any cognitive, are there any memory issues? Are we beginning to see some what we call executive functioning concerns? Mm-hmm. And if there are some concerns, it will help, the results will give the neuropsychologist an idea of, are we dealing with changes that are solely related to Parkinson's? Are we beginning to see a dementia or an Alzheimer's? Are there other types of issues that are coming into play? And that may make a difference of whether or not this individual would have a positive response with surgery afterwards.
Right, because it sounds like you're saying that those people may not have as good an experience with
Correct. So if we're beginning to see the onset of dementia or an Alzheimer's, actually going through brain surgery could speed that process up more than the natural course. And so even if somebody's tremor gets better, they could have a bigger decline in their cognition than they would otherwise if they had just proceeded without the surgery. And so that comes to that weighing out of the pros and cons, of the benefits and the risks of moving forward with the next therapy.
Yeah. The other piece of the candidacy evaluation that maybe was a little intimidating is the off testing. So does that mean you have to be totally off your medications? Every single one?
It is definitely everybody's least favorite day to come into the clinic. It's a really hard day. And so for those that have been through it, those who are considering it, I thank you very much. It is a really important day for the DBS team to have an understanding of what are you dealing with at home, what are your core symptoms. So it's a very informative test, but it is certainly a challenging one to go through. Different DBS centers may have slightly different guidelines. At UC Davis, we have you stop your Parkinson's short-acting medications 6 p.m. the night before, and your longer-acting medications will actually have you come off 3 days before, 72 hours before. So it can be a challenging day because most people have not been off of their medications for many years, so they really don't know what they're like. Some individuals come in and say, this is not what I'm like at home, I'm usually much worse, and they're doing much better than they would have thought. And other people who would normally be able to walk might need to come in a wheelchair. So it can be a very challenging day. As soon as we get through the videotape, we will get people back on their medications and try to get them back to a more comfortable state as quickly as we can.
Yeah. So as difficult as it is, I know we've had some cases in which we do the on medication and the off medication testing, and they're pretty similar.
Right.
So what does that mean for their candidacy?
So it throws some questions of whether or not deep brain stimulation in particular is the right step to go forward. So we can go through all of this. There's a very in-depth workup and then an in-depth process to get through surgery, and then these individuals might fall flat on the other side. They're just not going to see any of the benefit that they were hoping for this, and that can be very disappointing. And then they took all the risk on without the benefit of the surgeries. And so the individuals that will respond the best are the individuals that will have a more robust response to their medications. Now, there can be some exceptions because sometimes we don't see a difference, but it's really because their medications aren't not maximized because they can't take them, because their side effects are so awful that they're not able to get up to a therapeutic level. And so there's not really a difference between on and off. And so then we have to dig a little deeper in the history of when you have taken medications in the past, did you notice an improvement in your tremor? Have you had some positive responses on your movement that maybe you're not getting anymore? That might give us a little bit more clear understanding that they still are a good candidate, even though if we're not really seeing the clear numbers in there. So there can be a lot to take into consideration with that final decision.
Yeah, and that's a good point, because sometimes when you're bombarded by side effects, you kind of forget what the benefit was of those medications, and that's really important, it sounds like, for you to take into consideration when we're deciding whether or not they're a good DBS candidate.
Yes.
Good. Thank you so much. When you are counseling patients, Laura, with regard to, let's say they've made a decision to go forward with deep brain stimulation, we have a lot of options and a lot of choices, and I feel like the field is getting more and more complicated for patients, but that's why we're here. We're here to really help navigate through. Maybe you can break down what some of those choices are, starting with rechargeable or not rechargeable.
Yes, so the last few years have been very exciting within the deep brain stimulation field, because there's been so many technological advances, which is definitely making our job a little bit more challenging, as there's a lot of nuances. But at the core basis of that neurostimulator that's implanted in the chest, some individuals it could be in the abdomen, depending on what else they might have implanted. Is the traditional battery is what we call a primary cell battery. So this is a battery that would get implanted, and it's a set and done. So it is in there for 3 to 5 years. Sometimes it will last longer. Sometimes it needs to be replaced a little bit earlier, depending on the setting somebody's using. But it's something that they don't have to worry about until their battery needs to be replaced. It is something that needs to be monitored intermittently. So if you change providers and you don't have somebody monitoring your deep brain stimulation, you're at risk of that battery depleting without somebody monitoring it. So we need to make sure somebody's staying connected with a deep brain stimulation provider over the years. But another option is if individuals are looking for something that is longer lasting, there's a rechargeable option. And these options that are out in the market now are all approved for 15 years. So they don't need to come back in for surgery. They might be able to get through several batteries without having to come back in, whereas if they had that primary cell, they may have needed 2 or 3 batteries during that time frame. But these will be batteries that they will have to take responsibility to recharge. And depending on the companies and the device that they're using, they might need to be charged every day, or they might need to be charged about once a week. There's some variations in sizes, but both great options.
Yeah. So that does entail another surgery, though, if we are going to replace a battery.
Yes.
What's that like?
And that sometimes is one of the reasons that some people will choose to have that rechargeable, is they just the idea of having less frequent surgeries, less anesthesia over their lifespan can be really attractive. So if they feel that they can take on the responsibility of charging their system, or they have a caregiver that can help them with that, then that might be a really good option.
Great. Maybe you can tell us a little bit about some of the other features, the new features that are available now in terms of the DBS options.
So currently we have 3 companies that are to market, and all of them, we have Medtronic, Boston Scientific, and Abbott St. Jude, and then AbbVie, which is the Duopa company. All of these companies are part of our exhibitor hall. So on the virtual booths, you can go into any of their exhibit halls and get an opportunity to see their equipment, ask them more direct questions, and get more information. So you can get more specifics on their vendor booths. But specifically with the 3 deep brain stimulation companies, the general equipment is very similar between them, but they've all modified the technology and with different approaches. So traditionally on the electrode, on the lead, there's 4 electrodes. So the lead is placed in the brain, and there's 4 layers of electrodes. And we can push, when we turn the stimulation on, we're pushing the stimulation out in all directions. And the challenge has been that if that lead is a little bit too close to other structures in the brain, it could cause side effects. And so what has occurred over the last years is the companies have developed these directional leads. And coming this spring, all 3 companies will have a directional lead that will be available. And with the directional lead, if you think about this, you take a piece of pie and you cut it into 3 pieces, you can basically turn on or off different segments of that stimulation. And so you can steer the stimulation field to move away from structures that might be causing side effects, or to move more directly towards the part of the brain that you think is helping to reduce some of those symptoms. So that's probably been one of the biggest changes. And then within that, with the newer batteries that are coming out, there's been some structural changes, so the edges are becoming a little bit more contoured. We're hoping that we'll see less tissue erosion, less irritation from the batteries that might be irritating the skin and putting up people at risk of infection. They are hopefully becoming a little bit more comfortable as the newer designs are coming out. There's some new programming features in there too, so we have some expanded abilities to modify some of the parameters that we change that can reduce some of those side effects that often can limit our abilities with deep brain stimulation. And where the technology is moving towards in the future, there's some new technologies that are coming out that are trying to take a little bit of the guesswork out of programming, which can be quite lengthy. As any of you who out there may have deep brain stimulation know, the visits can last an hour or more. And what they're looking at is being able to have more adaptive deep brain stimulation down the road, where the system can garner brainwave activity and give us some more guidance. So we have some more objective measurements to help us better target the stimulation. So there's a lot of changes that are available to us right now, with a lot of technology that's going to be continuing to progress.
I think that's so exciting, right?
Yes.
Because wouldn't it be great if the deep brain stimulator knew that I was speaking and needed my maximum vocal projection ability,
Yes.
not moving, right? So
Right.
I don't really need all of the mobility and the improvement in stiffness and slowness. I just need my voice. But then if you go and play tennis, you're not speaking at all. So you can turn it up and really give maximal motor benefit.
Yes.
Right? So I think that really is the future, and I'm really excited about the adaptive technology
Yes.
that's on the horizon. Dr. Hadi, you have experience with patients who have had the Duopa Pump, and maybe you can tell us a little bit for our audience what it entails in terms of the procedure and how it works. What will they need? They kind of need a battery of a different kind, right?
That's right. So Duopa Pump basically is dopamine, but it is slowly infused using a pump that hangs on the waist or somewhere, and the tube goes into the proximal part or just past the stomach, because that's where we believe the best absorption of dopamine takes place. And so it involves basically having to see either a radiologist or a gastroenterologist who will first assess you and see and then basically it involves putting a very special tube that goes into that area. But before that, you have these people need to be screened, and this is basically, first of all, we need to see why do they need it. I mean, this is one of those long-acting dopamine therapies trying to mimic brain's own slow release process, and in turn helping minimize dyskinesia with improvement in motor symptoms of Parkinson's disease. So it's a stepwise process, and then we have to see if they are able to manage this pump, or if they have a family member or somebody who can help manage this pump. So it requires a few screening steps, but that's basically how it is. And then once it's placed, then after that people get these dopamine cartridges that are placed in this pump, and that has to be changed every day. The infusion starts in the morning, lasts up to 16 hours, and after that it stopped, and people take their own oral medication at night, so that can help them through the night. In the morning the infusion starts again. So it does require some manipulation of the pump, so that's why we have to see if a person or a caregiver or a loved one can help manage those. So a few steps are required there.
It seems like for both of these interventions, it's really helpful to have a care person or a family member or someone who can help navigate. Laura, it sounds like for deep brain stimulation, it does involve a lot of visits, right, to a specialty center who can do this programming on a regular basis, and also for the Duopa Pump. So both of those, that's important to note, I think. With regard to Mr. T, our patient, do you think that these surgical interventions would improve his primary complaints? So really what it came down to in the end was motor fluctuations and dyskinesias. Do you think he would get benefit in those challenges?
Yes, just off of the case, he sounds like he'd be a really good candidate. Specifically with deep brain stimulation and as well with the Duopa, these therapies can offer more consistent on time throughout the day. So those ups and downs that people have as their medications are wearing on and off will still be there a little bit, but they'll be muted out. And so they'll have more consistent on time throughout the day. So what we usually counsel individuals when they're trying to decide, is this something that they want to go forward to, if they feel that it would be a success for them to have more of that functional time, and that if they just had a little bit more of that without the troublesome dyskinesias, then these can be appropriate therapies to go forward. If they feel like how they are when they're on is not going to meet their need, maybe because they have severe balance concerns or other issues, then there should be a further discussion about what's really bothering them and what types of therapies would match up with that.
Yeah. One of the questions that comes in quite often is, does this take the place of my medications? Will I still need to take medications even after I go through deep brain stimulation?
Yes, so you may run into the rare person here and there who has stopped their medication, but that is definitely not something that we advertise, and it's not a goal of these surgeries. So you will, some of it depends, there are a variety of locations that we can implant the lead, and one of them more than the other can help us reduce more medications. So we can sometimes reduce up to 50% of medications, but people will still need their medications. And particularly with deep brain stimulation, this therapy addresses the motor symptoms, the tremors, the stiffness, the rigidity, the slowness. It does not help with all those other non-motor symptoms that the medications help. And so as we start reducing some of those medications, sometimes we'll find some of those symptoms will begin to flare up. And so we have to find that happy medium of the best medication balanced out with the best amount of surgical therapy.
Yeah, I think that's a really good point. You know, sometimes it's such a mental effort to go through with something like brain surgery, that the expectation might be then to, oh, this is now going to take the place of all of my medications. And I've definitely seen in my practice, I'm sure yours too, where the withdrawal of some of that dopaminergic therapy is really associated with kind of unmasking of other issues like apathy or depression, right? Because sometimes the medications are kind of inadvertently helping with those too without us even realizing it. So gosh, there's so much to consider. It's a really, really challenging decision, but I encourage all of you to have these discussions with your movement disorder team. So thank you again, Dr. Hadi and Laura Sperry, for your insight and perspective in tackling some of these really challenging motor complications of Parkinson's, namely motor fluctuations and dyskinesias, and how they relate to our surgical options for therapy. So I now invite Sean Tracy, President of the Parkinson Association of Northern California, and Barbara Fleck, Executive Director, back for some closing remarks.